Mental health among the geriatric population is a very unique field that has slowly been surfacing over the past few decades. I won't say it's a new field because I believe that patients have always struggled with this. However, only more recently has society been more accepting of this field and patients are becoming more comfortable with reporting their symptoms. Mental health was kind of a taboo topic a long time ago, and even though our generation is more used to talking about it, for the majority of our geriatric patients' lives, there has been a stigma around mental health disorders, resulting in a severe lack of diagnosis and therefore treatment for these geriatric patients. Elderly patients aren't immune to any mental disorders just because of their age. In fact, many geriatric patients suffer from a range of disorders, including anxiety disorders, PTSD, schizophrenia, bipolar disorders, depression, substance abuse disorders, and the geriatric population actually has one of the highest suicide rates compared to other age groups. Almost 20% of adults 55 or older have experienced some kind of mental health disorder, and close to half of the geriatric population diagnosed with mental health conditions have unmet care needs, likely because of patients not reporting symptoms in the first place or not speaking up about the severity of or any changes in their symptoms that would require a change in care plan. Around 10% of geriatric patients are diagnosed with some kind of anxiety disorder, while 25% struggle with significant depressive symptoms, and an additional 1 to 2% are diagnosed with major depressive disorder. But again, these statistics are based off of patients who have reported their symptoms, and the true number is likely higher. Around 3 to 5% of patients over 60 experience PTSD, and this might be due to those of our geriatric population that has served in things like the Vietnam War. It is so important to recognize the large number of the elderly that struggle with mental health issues in our society so that we can best treat them and get the proper care that they need. Mental health care for the geriatric population starts with assessment. When you prepare to perform a mental health examination, choose a private, quiet setting and use a calm voice to encourage open communication. Discover the patient's chief complaint and medical history, especially any past psychiatric history. Run a mental status checklist of simple items in your head, things like appearance, demeanor, attitude, body language, orientation, attention span, confusion, defense mechanisms, and self-destructive behavior. Then dive into the mental health exams. There are a lot of tools and tests at our disposal to properly assess and potentially diagnose mental health problems. These include the mini mental status exam, which measures orientation, registration, recall, calculation, language, and graphomotor function. There's the cognitive capacity screening exam, measuring orientation, memory, calculation, and language. The Beck Depression Inventory that helps diagnose depression, determine its severity, and monitor the patient's response during treatment. And the Global Deterioration Scale, which assesses and stages primary degenerative dementia based on orientation, memory, and neurological function. It is important to note that, while most elderly patients do well on their mental health examinations, if they perform poorly, it may be due to functional impairments rather than a mental illness. As we age, our brains start to retrieve and process data more slowly, which may result in slower motor responses or even the inability to perform tasks that are more complex in nature. To the untrained eye, the withdrawal and uninterested seeming symptoms of depression may look similar to the slower thought process of old age, so we as nurses need to be extra vigilant about performing thorough mental exams on our geriatric patients. As you perform these tests, look for abnormalities such as abnormal thought process, possibly manifested in derailment, flight of ideas, incoherence, made-up words or sounds, or remembering things that never happened. Abnormal thought content, which could look like obsession or compulsions, phobias. Abnormal perceptions, which is something like illusions or hallucinations. These abnormal assessment findings could lead to mental health diagnoses such as major depressive disorder, delirium, PTSD, substance abuse, and many others. Also things like Alzheimer's or Parkinson's, but those are more on the cognitive side of things and not exactly mental health, but these tests can still help determine those. Some of the most common disorders among the elderly population are depression and anxiety. While depression is not a normal symptom of aging, it's not uncommon in geriatric patients either. In fact, it's a major reason why elderly people are admitted into nursing homes. However, these are only the people that are actually diagnosed. We still have a large inconsistency in the true numbers of depressed patients, and the number of patients actually diagnosed. Depression is more than just being sad. There are physical and hormonal changes in the brain. This can manifest, especially in geriatric patients, as somatic complaints like insomnia, decreased appetite, weight loss, memory loss, and even chronic pain. There are also the non-somatic complaints, which may be more helpful in patients who have had a previous diagnosis like cancer, where somatic complaints are very common. And these include lack of energy or motivation, increased dependency, poor grooming or other ADLs, withdrawal from previously enjoyed activities or people, and preoccupation with death or giving up. Once a patient is diagnosed with depression, our goal becomes mostly palliative care rather than curative. Our plans of care focus around decreasing their symptoms, reducing the risk of relapse or recurrence, and improving their quality of life. Because older people with depression tend to have higher recurrence rates, treatment plans may need to be longer than one for a younger patient. Patients and their families should be educated on the general treatment plan and timeline, discuss realistic goals, and talk about the available non-pharm and pharmacological approaches. Some of the non-pharm interventions include cognitive behavior therapy, social support, psychodynamic therapy, problem-solving therapy, etc. There are many different kinds of therapy, and it is beneficial to try out different kinds until you find one that works well for you. As far as pharmacological interventions go, there are over 20 different antidepressants available. Again, you should work with your primary care provider to find the medication that works best for you. Medications are chosen based off comorbidities, drug side effects, and the type of effect desired, whether that be more or less sedating or more or less of an effect on appetite or etc. The common classes of antidepressants are selective serotonin reuptake inhibitors, which are usually the first choice and have the most manageable side effects, then serotonin and norepinephrine reuptake inhibitors, which are the usual second choice if the SSRIs don't work well for that patient, and then finally monoamine oxidase inhibitors, which used to be the main course of treatment before SSRIs and SNRIs were invented, but now they're more of a last resort treatment because of their high side effect profile. Like depression, anxiety is a very common disorder in the geriatric population. Although only 10% of the geriatric population has a diagnosable disorder, 15 to 20% of patients exhibit subthreshold symptoms, meaning their anxiety isn't bad enough to warrant a medical diagnosis, but they still very much experience the feelings of anxiety. Anxiety disorders are often caused by medications and polypharmacy in the elderly, such as anticholinergics, digitalis, theophylline, antihypertensives and beta blockers, steroids, and even some over-the-counter medications. Anxiety manifests as unpleasant and unwarranted feelings of apprehension and can be accompanied by physical symptoms like increased heart rate, nausea and vomiting, sweating or shaking. Anxiety can cause social isolation and avoidance of previously enjoyed activities, which is similar to depression, which is why assessment skills and medical histories are so very important pieces of the puzzle that we nurses have to put together to form a correct diagnosis. Once diagnosed with an anxiety disorder like depression, our interventions become mostly palliative and centered around avoiding flare-ups or recurrence. And again, patients and their families should be educated on the general treatment plan and timeline, treatment goals, and the available pharm and non-pharm approaches. Some of the non-pharm approaches include, again, cognitive behavioral therapy like depression, then mindfulness-based stress reduction, and then exposure therapy, which is when you introduce fears into a controlled environment, kind of like when a kid has a fear of dogs, so you introduce them to a very calm puppy first, let them pet the puppy while you hold it so it seems less scary. Pharmacological interventions start with SSRIs, just like again for depression. Then the second line of defense is short-acting benzodiazepines, but those should only be used for short term and with close monitoring. And then non-benzodiazepine anxiolytic agents are also occasionally used. Under the umbrella of non-pharmacological interventions, there are many coping strategies that we can implement or teach families to implement in the care plans for geriatric patients dealing with depression and anxiety. Distractions that incorporate other senses like aromatherapy, music therapy, or pet therapy are often good tools to combat depression or anxiety. Things like exercise or a simple walk outside. Sorry, that was my boss that walked in. So distractions that incorporate other senses like aromatherapy, music therapy, or pet therapy are often good tools to combat depression or anxiety. Things like exercise or a simple walk outside can release hormones that will boost your mood. Sitting with your thoughts and writing them down and journaling about your day allows for self expression, and humor helps keep the mood light and cheerful. And perhaps one of the most beneficial things we can do to help our geriatric patients is simply offer support. We need to offer both the patients and their families our support and give their families resources to encourage constant support of their loved one. This can come in the form of lending an ear, spending some extra time with the patient, suggesting a support group for the patient and or their family, and pointing them to other resources available. Besides all of the previously listed medical diagnoses, there's the simple idea that getting old isn't easy. Your body can't do the fun activities you used to enjoy, and eventually the simple activities of life like dressing, bathing, and toileting yourself may become impossible. Hormones are changing that can affect your mood and make you grumpy, such as estrogen and progesterone in women decreasing or testosterone decreasing in men. Cancer seems like more of a looming threat. You're faced with the idea that you may have to leave your home to get the care that you'll need. You're approaching the end of your life, and you're reminded of it often as you watch friends pass on one by one. This sounds pretty depressing and anxiety riddled to me, so it's no wonder that mental health disorders can accompany old age. And of course, there are positives too, and not every geriatric patient will have depression or anxiety or any other mental health disorder, but it is our job as nurses to be prepared for the ones who do and to give them the proper care they deserve.